Alicia, a 25-year-old woman, presents to you with nausea, vomiting, tachypnea, and sweating. Her mother reports that she found an empty bottle of aspirin in the patient's bedroom. Physical examination reveals a temperature of 38 degrees Celsius, a heart rate of 100 per minute, a respiratory rate of 40 per minute, and altered mental status. Relevant laboratory values are as follows. Intravenous fluids are initiated, and charcoal and sodium bicarbonate are administered orally. The patient is transferred to the intensive care unit for further stabilization. What is this patient's serum anion gap? The following equation is typically used to calculate serum anion gap. Potassium is typically not included because of its small contribution, as it is predominantly an intracellular cation. This patient's anion gap is 22. A normal anion gap is between 6 and 12 milliequivalent per liter, so this patient has an elevated anion gap. What is the acid-base disturbance in this patient? A mixed metabolic acidosis and respiratory alkalosis. The pH lower than 7.35 indicates acidemia. Respiratory acidosis is unlikely given the below normal pressure of carbon dioxide and the high anion gap. In this setting, the low bicarbonate indicates metabolic acidosis. Applying Winter's formula, the expected pressure of carbon dioxide should be 33.5. The compensation in this case is therefore excessive, suggesting an independent respiratory alkalotic process, which is consistent with a respiratory rate of 40 per minute. What are the causes of the two main types of acidosis in this patient's condition? Metabolic acidosis derives from the loss of bicarbonate or the retention of acid, leading to a non-anion gap acidosis in the former and an anion gap acidosis in the later. A non-anion gap acidosis is always the result of conditions that result in hyperchloremia. The major causes are as follows. The excess chloride suppresses bicarbonate reabsorption. Metabolic acidosis that is caused by retention of acid results in an anion gap metabolic acidosis because unmeasured acidic anions are retained. The major causes of anion gap metabolic acidosis are as follows. What are the causes of respiratory alkalosis? Anything that stimulates the central respiratory drive and causes hyperventilation, such as cerebrovascular accidents or neurologic disease, can cause respiratory alkalosis. Hypoxia, such as that caused by anemia, high altitudes, and pulmonary disease, can likewise increase respiratory rate and cause respiratory alkalosis. Other hyperventilatory states, such as mechanic overventilation or voluntary hyperventilation, such as in cases of anxiety, can also be causative. What is the pathogenesis of this condition? Aspirin is hydrolyzed to salicylate once ingested. At toxic levels, salicylates cause a primary respiratory alkalosis by stimulating the medullary respiratory center to hyperventilate. Salicylate also stimulates skeletal muscle metabolism, increase in oxygen consumption, and carbon dioxide production. This further stimulates hyperventilation. The metabolic of this component occurs because salicylate causes both lipolysis and uncoupling of oxidative phosphorylation, resulting in the production of organic acids, pyruvate, and ketones. How is this condition treated? Salicylate poisoning is treated with sodium bicarbonate, which alkalinizes the serum and urine. Alkalinization promotes ionization of salicylic acid to form the organic anion salicylate plus hydrogen. Because salicylate is a charged species, it becomes trapped in serum and urine and is unable to pass through hydrophobic lipid membranes and into cells. This inhibits diffusion of salicylate through the blood-brain barrier and into the central nervous system, as well as promotes excretion through the urine.